So, Sawadika, Mikalaba, Salawan Sien. Good afternoon, ladies and gentlemen. So, thanks to join today's online seminar. I'm Nina, the Director of Overseas Medical Mission Center of Changhua Christian Hospital. And I'm also the moderator of today's seminar. So, first of all, I would like to express my highly appreciation for all of our friends from different countries, different sectors to join us today's seminar. Special thanks for our three speakers. As you know, artificial intelligence, AI, has the potential and also the global trend to transform the healthcare delivery model. So AI can increase the productivity, accuracy, and efficiency of care delivery and provide the better healthcare system to more people. So AI also can help the diagnosis of healthcare practitioners, let them to spend more time in direct patient care and reducing burnout. Machine learning is particularly helpful in different areas such as CT scans, MRI skin images, pathologists, and eye images as well. So today, our seminar will focus on applying AI solution on medical service to help finding the indicators and diagnosis the diabetic retinopathy disease. It's our great honor to invite three speakers to join us today. So they will share their clinic experience with us. Two speakers are doctors. One is from Changhua Christian Hospital, and the other one is from National Taiwan University Hospital, respectively. And the last speaker is from Acer Healthcare Inc. So first of all, let me remind each of speaker, you have 15 minutes to present your topic. So Q&A is after all speakers finish their talks. All speakers, please control your time. Thank you. So for our attendance, if you have any question, please use the chat box in your right hand, the lower right hand. So to leave your questions. So I will collect all questions for speakers to respond after the presentation. Well, so the first speaker is Dr. Ting Hsieh. Dr. Hsieh is the clinic assistant professor of Department of Ophthalmologist, National Taiwan University Hospital. He's going to share AI solutions from an ophthalmologist standpoint, the future of healthcare. So Dr. Hsieh, the floor is yours, please.
Okay, thank you, Nina. And good afternoon, Professor Du and all doctors, friends from Taiwan and other countries. It's my honor to have a speak today about AI from an ophthalmologist point of view. Okay, let me share my screen first. Okay, I'm going to talk about the AI solutions from an ophthalmologist standpoint, the future of the healthcare. We know that AI is very powerful in image recognition. And not only they can recognize the birds of different species, they can even recognize different birds of the same species, which I may not be able to do that. So it is, we may think that AI might be helpful for us in the medical images. For example, the fundus photography is the first image that AI try to intervene or try to help us. In 2016, the Google team, they first developed the AI model, the deep learning model to diagnose the diabetic retinopathy from fundus photography. And the accuracy is similar to the ophthalmologist. Later, several teams from different countries, they can use the AI to diagnose glaucoma, age-related macular degeneration, and even predict the cardiovascular risk, and even predict the age and sex from the fundus photography. So now we know that AI is very, very good in doing these kind of works. But do we really need AI for all of these? Do we really need AI to do the prediction of age and sex? If you want to know why do we need AI in healthcare, we must look at this point. AI can help us in healthcare if it can help us save cost, improve quality, and increase access. Actually, the latter tools are just the problem we are facing when we are doing the diabetic retinopathy screening. So that's why we need AI for diabetic retinopathy screening. Among all the complications that diabetic patients might have, what they are most concerned with actually is visual loss. So the retinopathy, the diabetic retinopathy is very important complication for diabetes. According to the ADA guidelines, fundus exam for DR screening is necessary at least once a year. But in Taiwan, actually only less than half of the diabetic patients receive fundus exam for diabetes screening every year. Why? In Taiwan, we have the so-called the best national health insurance covering almost every people in Taiwan. So medical fare is not a problem in Taiwan. But why the screening rate is not so high? There are several difficulties we are facing. The patients, they visit internal physicians or general practitioner for the diabetes. So it is easier for them to do the DR screening by the fundus photography. But actually not all of the internal physicians are interested in doing this. Especially some of them are not really confident in making diagnosis by themselves. If they refer the patient to the ophthalmologist, some patients, they do not want to do so because they feel they will spend too much time if they referred to the ophthalmologist for the pupil dilatation and do the fundus examinations. Even all the patients that want to visit the ophthalmologist, actually there are too many patients for the ophthalmologist to do all the diagnosis screening for all the diabetic patients. So these are the difficulty we are facing for the screening. Even we are doing the successful DR screening and the patients, they are suggested to referred. In USA, there is a data that only 23% accept referral once they are informed they should be referred. There are many possible reasons, and one of the reasons is that delayed reporting may result in less awareness of the importance for referral. So we want to screen all the patients. We want to do that, but actually we can't do all of the work. So that's why we need AI to help us. In 2017, the National Taiwan University cooperated with the Acer to develop the model for diagnosis of DR. We use the image not only from the IPEX dataset, the open access IPEX dataset, we also use the images from our hospital because of the, we know that different, the image from different races taken with different machines might result in some differences. So we recruit not only the open access dataset, but also the image from our hospital. And we use this image to develop the deep learning algorithm and do the training and validation. That's the result we have if we only use the open access IPEX data only. And we validate the model with the patients from our hospital. The sensitivity is not so good. So obviously there is some gap between the IPEX dataset and the patients from Taiwan. So if we add the data from our hospital to the model for development and we validate the model with different patients, but also from Taiwan, we have a much better sensitivity and specificity. In this study, we are not only compare the VeriSee, the deep learning model to the ophthalmology, we also compare them to internal physicians because that's what we are facing in the real world practice. Actually, internal physicians, they took the, they do the fundus photography and they do the diagnosis by themselves. It's nice to see that the accuracy between VeriSee and ophthalmologists are similar. But we can find that the accuracy for internal physicians is less a little bit poorer than VeriSee and ophthalmologist. We cannot say that they are poorer, but they are not that professional than ophthalmology, and they have to do the diagnosis in addition to their clinical work. So it's very reasonable that the VeriSee can have better results, and that's why we need the AI to help us in clinical screening for diabetic retinopathy. And during the clinical trial, we enrolled another group of different patients to do the validation, and we still found the sustained good sensitivity and specificity for the VeriSee DR. So we got the approval from the FDA in Taiwan for the Diagnostic DR. But even the sensitivity is very good, 95%, even better than IDS-DR. We are still curious, what about the other 5% of patients? Because it might be dangerous if the patient with most severe form PDR and they are not diagnosed and they are not referred. So we want to see that what kind of patients the VeriSee DR cannot diagnose. We look at all the patients with false negative result that they are diagnosed as PDR by the ophthalmologist. This is the first one. The ophthalmologist that diagnosed it as PDR because there are laser scar. So we naturally think that they are PDR. That's why they received the laser. But actually, if we look carefully, there are no active lesion, no MV, and even no hemorrhage, no microaneurysm. So I think it's forgivable. So, I mean, it is not that bad if the AI cannot diagnose it as referable DR. This is also another one. Because of that extensive laser scars, so the ophthalmologists think it is PDR. And there are some fibrotic tissue, but there are no retinal detachment, no MV, even no hemorrhage, no microaneurysm. And also, this is another one. The ophthalmologist diagnoses it as PDR. But when I look back of this picture, actually, I'm not sure if it is really PDR because there are fibrotic tissue in the vitreous, but it might not be due to diabetic retinopathy. It is possible that it is due to another disease, not really DR. And this is another one diagnosis as PDR by the ophthalmologist. We can see that there are neovascularization at disc. So actually there's MV. But what about other features? We can see some subretinal fibrotic band here. Actually, this is really seen in DR. And besides these MV and subretinal fibrotic band, actually there are no active hemorrhage, even no obvious microaneurysm. So there is this is disease eye, but is it really a PDR? Actually, I'm not quite sure. So among all the certain cases that are diagnosed by the ophthalmologist as PDR, but are diagnosed by the non-referable by the VeriSee, actually they are not really typical PDR, and actually most of them have received treatment before, or even they are different kind of disease. So I think it is quite let us feel that it is we should take our rest to let the VeriSee do the diagnosis, and that's why it got the FDA approval also in Taiwan and Thailand. Amy will give us more information about this later. So how can we make the most use of the AI diagnosis? If we put it in the cloud, there might be some problem during the internet connection or what. So the best way is to incorporate it into the hospital's EMR system. So then we can have the immediate diagnosis and immediate report after we take the fundus photography. So only we have the easy way to do the diagnosis, not only easy, but also quick and immediate result from the diagnosis, and we can only do the timely referral and timely treatment for the patient. So that's the three wing for the internal physicians, for the patients and also the ophthalmologists. Because for us ophthalmologists, we don't want to do the screening work. We want to have the patient who really need treatment and they come timely. They don't come too late. As the AI, we are doing the further development, not only for DR, but also for age-related macular degeneration and glaucoma in the future, and even for risk evaluation for systemic disease. But we have to know that AI, actually, they are here to help us, not to replace us. So thank you very much. This is my talk.
Thank you very much for Dr. Hsieh. Yeah, it's a great talk. So the second speaker is Dr. Du. He is the superintendent of Changhua Christian Hospital Diabetes Institute. He is also the physician of endocrinology and metabolism department. So Dr. Du, we're going to share the impact of VeriSee DR implementation of diabetes care management at Changhua Christian Hospital. Dr. Du, the floor is yours, please.
Professor Hsieh, Amy, and Nina, and dear colleagues all over the world, good afternoon. And it's my great pleasure to share the experience of VeriSee DR in Changhua Christian Hospital. And I'm Hsieh. I'm an endocrinologist and a diabetologist. As we know, there's an old saying that the good healer cures the illness that is about to break out. So when the physician, when the diabetologist faces a patient with diabetes, he faces a seven-head monster. Why? Because he needed to survey if any micro complication or other macrovascular complication. And when he aged over 65 years old, he needed to survey the patient is any osteoporosis because the patient is high-risk group for osteoporosis. He also needed to choose the right medication for diabetes, hypertension, hypercholesterolemia, even urge them to smoking cessation. So when a physician faces a diabetic patient, he has limited time. How we can survey the patient's microvascular complication in an efficient way? There was two ways to do the job. The first one is teamwork. The second one is the pathway standardization. So in Changhua Christian Hospital, we have more than 10 certified specialists. They are all certified diabetes educators. Also, we have certified diabetes educators, and then we have 3 certified registered dietitians. They was also a certified diabetes educator. Also, we have a large room for case management center. It's a EM center. So in the space, we can have patient enrollment assessment. And we want to provide a one-stop service for our DM patient. So all kinds of complication survey was done in this space. And we teach them how to self-management education, including nutrition counseling, medication counseling, and lifestyle modification. So this is our photo of the case management center. As we know from the speech from Professor Hsieh, diabetic eye disease is a much feared complication of diabetes, and it consisting predominantly of diabetic retinopathy, diabetic macular edema, cataract, and glaucoma. And if we can early diagnosis and a timely treatment, then we can prevent the patient vision impairment and blindness. So it is very important for our diabetes management. So at Changhua Christian Hospital, we have according to congestion with the program guideline, we have a lot of mandatory diagnostic tests for each DM patient. And this was ordered as a packaging upon enrollment. And this is very important, is we have a machine for retinal photography by our technician to do the job for our DM patient. And we also have some information system for us to refer the patient to ophthalmologist by single click. We can make a reservation for the OPD visit. So this is the original patient drawing at CCH. The patient, when they come to our OPD, then we assign them to do the DR screening. Then our educator or our technician will take color fundus image for patient. As you know, like the Professor Hsieh said, the ophthalmologist do not want to interpret this simple fundus image. So the job was dependent on our endocrinologist to interpret the image and science diagnosis report. After we finish the report, if any abnormality find, then we will refer them to ophthalmologist for treatment. This is our original patient drawing. But they have some pain point during our previous patient drawing. The first one is per month, we have over 1,500 patients needed to refer us to do the retinopathy screening. So he's a huge reading. The second one, as you know, the photography was taken by our educator or even our technician. So there is no image quality check during the large work loading. And like the saying of Professor Hsieh, we are internists. So we are not trained by special eye training. So DM doctor was not eye specialist. So per day, we needed to finish 45 reports per day. And this was divided to our more than 10 endocrinologists. So some is young, some was very experienced. So it's harder to complete the job in the same day appointment. So when we needed some delay in the report system, so we will refer to the ophthalmologist were in a delay pattern. So delay refer and delay treatment. And as you know, ophthalmologist is very busy. There is very difficult to have an OPD to have a registration. So we delay the patient for his treatment. Now, after we implementation of VeriSee DR, they can ensure the quality of image because it was done by the AI. The second one, it provides a better care and the convenience for our patient. And due to the report was finished by our endocrinologist, so now we have AI support, so we can add confidence and accelerate the diagnosis. Then we design a system we will talk about later, why we can provide early treatment cooperation with our ophthalmologist. Maybe the next presentation by Amy, they will talk more about how to integrate in VeriSee DR with His or PEX. But as I know, due to Acer have a cooperation plan with Changhua Christian Hospital, they can customize. Even they can produce the automatic report, send via email, or use other file format or other needs or requests during the hospital and the company. So I will make short introduction in that. And after we use the VeriSee DR, you can see when we take the photo from the patient retina, the PEX upload the image, and the AI can automatically display our VeriSee DR result. Then they will get to the first one is the quality of the image. So it's good or bad. So the photo quality was adjusted, analyzed by the AI we just click the button of the AI button, then he automatically produce the result, and then he interpret that is the patient right eye have no apparent diabetic retinopathy, or the left eye have mild non-proliferative diabetic retinopathy. Then they will automatically have suggestion, refer or non-refer. As an endocrinologist, we just click the button, generate, then the result automatically produced, and we finish our job in interpreting the photograph of retina. And someone were curious about the result from adjustment analysis by physician or just by the AI. This is the result from 2020 November to 2021 January. We have 35 work days. We have analysis about 1,595 patients, and random select 299 cases for analysis. And you can see they have good agreement, over 90%, between the team of DN, Dr. at CCH, and the VeriSee DR. And this is a very high level agreement. And we can reduce the time it takes DN doctor to interpret fundus image. As I present earlier, we just click the button and the report will produce in seconds. Then we just compare the photograph from the PET, then to decide, make the agreement with the machine or just by our adjustment. But you know that 91% is totally agreement. And so we can accelerate the diagnosis process. And some physicians were curious about the 9%, which was not in agreement. So we make the analysis of the agreement, and then we found that over 66%, there was no diabetic retinopathy or mild NPDR. Why? Because 66% non-agreement because our patient is old. More than maybe 50%, their age is over 65 years old. And some have cataract, and some cannot dilate their pupil. So they have some disagreement between our physician adjustment and the AI. So, but the result was between no DR or mild NPDR. And this was actually set up as non-refer. So it didn't influence the result. We want to refer the patient to ophthalmologist. And the 30% disagreement between non-DR, reasonable, and unable to analyze. As I say, some patients due to cannot dilate their pupil or they have cataract, so they cannot make analysis. So this is bad image quality. And only 10% was other disagreement. As I mentioned previously, the implementation time will shorten. When we have no AI, we will delay the job because we are very busy. So when I needed to make the report, we always delay. So maybe 1 month or 2 months, we just finish the report process. And every time when we see the photography, we needed to take 5 minutes to see how is the abnormality and make the report. But after we use the AI, they increase our confidence. So less than 1 minute, we can accumulate the report for the patient. So it has 80% decreased the interpretation time. And after we use the AI, we have a dedicated DR clip. We cooperation with our department of ophthalmologists. So our ophthalmologists who are major in retinopathy, they assign a everyday clip from the morning to afternoon. So they can access our green channel for us to do the same day refer accept. As we know before, we finished the report in delay process. so maybe weeks or months, then we refer to the ophthalmologist, but their OPD is always busy, and we can reduce them to them. We cannot refer them to them in the right time, so some patient will visit NTUH Professor Hsieh because he had other routes for earlier visit. But after we implementation the AI, we can analyze the report in the same day. And we use the green channel for the Hsieh DR clinical ophthalmology in a very quick time interval. And the patient can access to the right treatment in days. This is our information system. We have a special registration clinic for them because diabetic retinopathy OPD. So we choose it, then we assign the patient without the name of the physician, it's just OPD. Then which time you want the patient visit the DR clinic, you can choose. Then we have 6 ophthalmologists who is specialists for the diabetic retinopathy in Monday to Saturday. In the afternoon or morning, they provide a special OPD for our referred diabetic retinopathy patient. As you know, we have a lot of patients with maculopathy because there is a special disease for old age group or DM patient. And after this patient refer to DR clinic, they make a comprehensive eye examination before they have a face-to-face consultation with our ophthalmologist. They do the visual acuity, they check the intraocular pressure, they have an optical coherence tomography, and they use an ultra-wide field photography again. For the funders, as you know, our machine is not ultra-wide field, so some lesion will under diagnosis. But when we refer to the ophthalmologist, they use ultra-wide field photography for the patient, and they do the pupil dilatation. So after this comprehensive eye examination, our ophthalmologist can have a good diagnosis and make a good treatment plan for our diabetic patient. So after we use the VeriSee DR, you can see our patient generally have some change. The first one is image quality check system, ensure fundus image are readable by doctors. The second one, it increase the confidence of DM doctors in diagnosing disease. When we have the diagnosis, our back have some Professor Hsieh. He told us this is right or this is wrong, this should be referred or this should not be referred. We have automatically Professor Hsieh as our support for diagnosis. And we can only take less than 1 minute, 60 to 80% faster than before. And so we can have more time for our patient to increase the screening rate, and we have better quality of care for each patient. And the DM patient also satisfied because they can right away refer to ophthalmologist in a timely fashion. So early treatment to prevent the vision loss, even blindness. Last of all, I will make a summary of the impacts after we implementation of VeriSee DR in Changhua Christian Hospital. From doctors and health professionals, DM doctor increase confidence. We can interpret image faster, less than 1 minute, and then we have more time for patient. For the ophthalmologists at Changhua Christian Hospital, they have more efficient and dedicated DR clinic that provide treatment faster. And then from other healthcare professionals like other internists, they can also have better efficiency and convenience to do the retinopathy screen for their patient and the treatment. For the hospital, we can increase the DR screen rate. We can retain the DR patient within CCH because after the cooperation with ophthalmologists, they can be sure to stay at Changhua Christian Hospital for the treatment for their DM retinopathy or even macropathy. So they have better patient outcome. For the patient, increased convenience and receive DR treatment faster. So they have better quality of care. To our society of Taiwan, I think after the efficiency screening system and the right treatment for our DM patient, they have better disease management, and we can prevent blindness and decrease the society burden. So this is my presentation. Thank you for your attention. This is the photo of our team. Thank you.
Thank you, Dr. Du. It's a great presentation. So the last speaker is Amy Hsiao. She is the manager of product strategy and management of Acer Care. Amy will talk about an overview of VeriSee DR, an AI-assisted diagnostic software for diabetic retinopathy. Amy, the floor is yours, please.
Thank you for your introduction. So good afternoon, everyone. I'm Amy from Acer Healthcare. And thank you, Dr. Hsieh and Dr. Tu, for your wonderful sharing. So after learning about their actual experience with VeriSee DR in real clinical settings, I thought you might want to know a little more about what VeriSee DR looks like and how it actually works. So before we begin, here's a brief introduction to Acer Healthcare. So we're a subsidiary of Acer, the company that sells computers and laptops. And our mission at Acer Healthcare is to improve human health and well-being through artificial intelligence. And specifically, we collaborate with hospitals to identify unmet medical needs. We utilize AI and big data analysis to develop intelligent medical products, and we provide AI-driven solutions to improve patient care and outcome. VeriSee DR is our very first product, and it's an award-winning diagnostic software that utilizes AI to analyze images of the retina for signs of diabetic retinopathy. And it's typically used in diabetes clinics or clinics that offer DR screenings. So as soon as the patients have their fundus images taken, VeriSee DR analyzes the images for signs of DR and provides immediate results on whether the patient should be referred to the ophthalmologist for a detailed exam or treatments. And specifically, our software is to be installed on the computer that's connected to the fundus camera. It can be configured so that as soon as it detects a new image, it will automatically start the analysis and output a referral recommendation within 3 to 5 seconds. So in terms of performance, as mentioned by Dr. Hsieh earlier, we conducted a formal clinical trial at National Taiwan University Hospital, and VeriSee DR reached a sensitivity of 95% and specificity of 90%. And these performances are comparable to ophthalmologists. And in terms of regulatory approval, VeriSee DR was the first ophthalmic AI software to obtain Taiwan's FDA approval in September of last year. And earlier this year, we further obtained Thailand FDA's approval. And we're now in the process of applying for approval in other Asian countries. So in the second half of this year, we expect to receive approvals from Indonesia and Vietnam. And Malaysia, Philippines, and Japan will be next year. So next, I will go over the actual user workflow and show you how the software user interface is like. So typically, after our customer purchases VeriSee DR software license, we will install the VeriSee DR on the computer that's connected to the fundus camera. And usually, as soon as the images are taken, they will be exported and saved in a designated folder. We can then configure VeriSee DR to automatically detect the new image and automatically starts to analyze the image in real time. So after it finishes the analysis, a report will be generated automatically. So basically, in such scenario, we can configure VeriSee DR to work in the background so that the user doesn't ever have to manually upload the images for the AI analysis. It's like you will already have the recommendation result in a few seconds after the patient's images are taken. So I thought I'd show you a quick demo here. So you see, as soon as the designated image folder detects a new image, the analysis starts, and you can see that the analysis only takes a few seconds, and this is the example with a referral recommendation. And you can see that a PDF report can be created with the option to add additional comments, and that can be generated with one click. So like this. And if you prefer to manually upload the images for analysis, we also have a very simple and user-friendly interface. So over here, you see the user interface to analyze the one eye at a time. So on the left, you may choose the one eye icon, and after you upload your image and hit the analyze icon, you will see the result shown here in the dial. So green means that the patient only needs to come back for regular tracking and corresponds to no DR or mild NPDR. And if you would like the report, you can just click on the create report icon and type in comments if you want and generate a report like this. And this is what it looks like when the result is referral recommended. And you will see a red result here. And it corresponds to moderate NPDR, severe NPDR, and PDR. And this is the user interface if you choose the two eyes function on the left. So this mode allows you to upload two images, one for each eye, and perform the analysis of both eyes at the same time. And this is the case when the result is regular tracking. You can see the green bars here. And this is when the results are referral recommended. You can see the red bars on the bottom. And in addition to the one eye and two eye functions, we also offer a batch upload function. So if you choose this icon on the bottom here, you can upload up to 1,000 images at a time. And after you hit the analyze button, an Excel table containing all the results can be downloaded. And this is what the table will look like. So we have the first column being the name of the image file, and the second column being the binary yes or no result of whether referral is recommended. And the third column tells you the stage of DR, and the last column tells you whether the image quality is good, fair, or bad. So please note that VeriSee DR has an image quality control system in place. So it has learned from the experience of ophthalmologists. So if the quality of the images is at least fair enough for ophthalmologists to analyze, then VeriSee DR can analyze the images. But if the image quality is so bad that even an ophthalmologist cannot analyze, then VeriSee DR will output bad quality image, and it will not be able to analyze the image. And this table summarizes the brands and models of fundus camera that we have already tested. But if your fundus camera brand or model is not on this list, don't worry. Please feel free to reach out to us for a demo or a pilot test. And the slide summarizes the recommended computer hardware requirements to run VeriSee DR. Basically, it doesn't require high computing power computers, so just a simple office computer should be sufficient. So to summarize the key features of VeriSee DR, first, VeriSee DR uses edge computing so that can do the analysis without requiring the internet, and you don't need to upload the images to the cloud, so there's no data privacy concern here. And second, VeriSee DR has a built-in backup program that automatically protects your data when AI is down, so you don't need to worry about losing your patient's images. And third, VeriSee DR can be configured to integrate seamlessly into your current clinical workflow. So we also offer customization services. So adopting VeriSee DR doesn't complicate your work. It's here to simplify your daily routine. And finally, VeriSee DR offers unparalleled performance with an overall accuracy similar to that of a specialized ophthalmologist. And I understand Dr. Tu showed you the real impacts of VeriSee DR in Changhua Christian Hospital. So here I will just quickly go over a study we did at Taichung Veterans General Hospital. So in this study, VeriSee DR was compared with endocrinologists, and we found that VeriSee DR's specificity of 84% is significantly higher than the 50% of endocrinologists. And we also found that VeriSee DR decreased the possibility of overdiagnosis by endocrinologists, and it increased the rate of grading the reports on time within 3 days after the fundus examination. And the results have been published in the journal Life earlier this year. And some of VeriSee DR's unique strengths are that the AI model is trained using data from the Asian population, and it does not rely on cloud computing, so no internet is required, which makes VeriSee DR an excellent choice when you need to comply with government regulations or when you want to use it in remote areas where internet is not stable. And we also support most camera brands, and VeriSee DR has obtained regulatory approval from Taiwan and Thailand already, and we're actively working on the other countries too. So in sum, VeriSee DR was carefully designed and innovated to meet the specific needs of the medical community and address the challenges of DR screening. And with our unique product features combined with customization, we've made the adoption of new digital technologies in the medical community much easier. And in the real world, VeriSee DR's accurate and immediate analysis results are already helping healthcare professionals. And as we continue to roll out VeriSee DR around the world, it's expected to make a greater impact and bring unparalleled values to healthcare professionals, providers, payers, and patients alike. So with that, I'd like to conclude my presentation. So thank you all for listening.
Thank you. Thank you so much, Amy. Thank you very much for all of speakers' presentation. And now it's open for QA. Anyway, if you have questions, you can raise your hands. Then I will know who is going to ask the question. Or you also can leave the question on the chat box so I can collect question. If no one asks question, I would like to ask our two doctors. So what is the most difficult part when you start to apply the AI on your clinic? And I think from the cause of effect view, and if you are the manager or you are the hospital's director, where you support, you will would like to introduce AI system into the Hsieh system or into your medical services, because that may be to add some of the cost. So I would like to ask two doctors, because one doctor, Dr. Hsieh, he is from public hospital. Dr. Du, he is from private hospital. So maybe they have different strategy. So Dr. Hsieh, would you like to answer?
Okay. Although my hospital participate in the development of the VeriSee DR. Actually, my hospital hasn't used this clinically. Just as Nina says, the public hospital has more strict regulations about the information security, and it is more difficult to incorporate between different departments of our hospitals. So it's just Professor Du and Amy said that the VeriSee DR have been incorporated into the Hsieh system, the medical record system of the hospital. But for my hospital, there is a lot of trouble if they want to do this. So they are still working on it.
Okay.
Yes, I want to reply the question. As you know, I'm so old. From my hair, you can see that I'm over 60 years old. And before previous 10 years, I don't report the retinal photography by myself because I'm a lot of work loading needed to do. So always this work was provided to younger generation physician. And as you know, the pay is limited, only $980 per report. So delayed report is a routine issue in our department. And Professor Hsieh said only 45% of patients received a retinal examination, but in Changhua Christian Hospital, more than 90% of our patients received this examination. So huge report need to be accomplished. And after we implementation of AI from Acer, I report it by myself because I only take about 20 minutes. I can finish almost 50 reports soon. So although it's limited, but I take the salary by myself because it let me feel it was very easy for me to accomplish the job. So as I know, I'm not a leader level in Changhua Christian Hospital, but when we use this AI to finish the report quickly, then we have some cooperation with our Department of Ophthalmologists because before, due to delayed report, we cannot refer our patient in efficiency way to our ophthalmologist. But now we can finish our job in an efficiency way. So we have a conversation with our ophthalmologist that we finish the job quickly. Can you provide us a good referral green channel for our DM patient? And they accept our suggestion. So design a DR quick for us to refer our patient for the right treatment. So from the viewpoint of hospital, more DM retinopathy stay at Changhua Christian Hospital. It means that more income from this patient from health insurance will come to Changhua Christian Hospital. And our patient do not need to travel to Taipei to visit Professor Hsieh because we have 8 ophthalmologists in our hospital can finish the treatment in Changhua. So I think for patient, for physician, for hospital, even for healthcare provider from the health insurance company, they can have a lot of benefit from implementation from this AI.
Okay, thank you, Dr. Hsieh, and also thank you, Dr. Du. And we are happy because we have different audience of friends join us our today's seminar. One of our friends, he is from Papua New Guinea, because he's taken the short-term training in our hospital. And Damien, would you like to give us some comments? Because I know Papua New Guinea, you have a lot of patients with diabetic, and you also have different or many of the problem of the eye. So would you like to give us some comments about today's talk? Damien.
Thank you very much, Nina. I would like to thank all the speakers for a very excellent and nice presentation. I'm from Papua New Guinea, and in Papua New Guinea, we've got lots and lots of cases with diabetes and also with complications as well, like retinopathy and all, etc. I just want to ask you, Amy, this question, like for these complications in diabetes in developing countries, will this be a suitable idea to implement in countries like Papua New Guinea for the diagnosis of degenerative eye diseases?
Thank you, Damien, for your question. So yes, I think our product, VeriSee DR, is definitely suitable for developing countries like Papua New Guinea. especially in areas where there's shortages of either diabetes doctors or ophthalmologists. It really helps the frontline healthcare professionals to do the screening screening first and identify the high-risk patients. So once we identify the high-risk patients, we can then transfer them to specialized ophthalmologists if necessary. So I think it's really going to be helpful in a lot of the developing countries in the long run.
Okay.
Yeah.
Can I have some answer for the question? As you know, ophthalmologists don't screen the diabetic retinopathy by themselves because when 10 patients need a routine screen, only one patient has retinopathy, but he needed spend 10 times to deal with the screening. So they only want to handle with the patient with DM retinopathy. So as the job from endocrinologist or even in your country, you just pick up the right patient for right ophthalmologist. And as I know, in our hospital, we have more than 10 ophthalmologists. So we can afford good service for our patient. But in your country, I think ophthalmologist is rare. And you don't even dream to help the very few ophthalmologists to screen DM retinopathy for you. You just needed to do you by yourself. Then pick up the right one, refer him or her to Australia or the country who has expert in ophthalmologists. Then you save the patient's visit and to prevent him or her to be blind. This is a very good job for you to improve your EM care quality.
Thank you very much,
Okay.
Prof. and Amy.
Thank
Thank you
you.
for your answers. Thank you very much.
Okay, so I saw one of the audience raise his hand, but he's off. Whatever, maybe we can ask question later. And so for Amy, so Acer, besides DR, Acer will develop a lot of AI system in the future.
Yes, we do have a series of VeriSee products lined up in our pipeline. So in addition to DR, we are also developing AI systems for age-related macular degeneration, AMD, as well as glaucoma. So in the future, maybe just with that one fundus image, we can use VeriSee series of products to see if the patient has DR, has AMD, or has glaucoma. So I think in the near future, we should be able to see that soon.
Okay, thank you. One of our participants raised his hand. So can I invite Dr. Prasaka?
Yeah, hi, my name is Prakash. I'm
Yes,
calling
please.
from Taiwan. Happy to listen to this wonderful discussion on the AI product. I would like to ask a question about the utility of OCT other than the fundus images. So is Acer or any other previous speakers working on integrating the OCT images as well into the AI?
Amy, can you answer?
Yes. So for OCT, it's also in our plan. We're planning, but it's a little later than the fundus-based AI systems. So we'll continue to collaborate with ophthalmologists like Dr. Hsieh to explore opportunities of how we can accelerate and better integrate AI with OCT instruments.
answer the question asked by Prakash, because when we focused first is for the screening, and it is not that popular to use OCT for the screening, not for DR or for other disease. Maybe in the future, yeah. And besides, for the DR, for the diabetic patients, OCT is more practical for the diagnosis of diabetic macular edema, but it might not be that helpful for the diagnosis of referable DR, including severe NPDR or PDR. But maybe we will focus on the more detailed findings, such as diabetic macular edema or macular ischemia using OCT in the future.
Can I ask a question to Professor Hsieh? After we use the AI in our hospital, do you have any plan to design a DR 2.0 version in the future? Because maybe after we use it in real world, we can feedback some opinion to you or Acer. Do you have any plan to upgrade the software to a more perfect status? As I know, DR AI system is rather popular all over the world. I ever visit China. They have more than 5 companies develop the DR AI system. My second question is, under your design, do you think the best part of our AI from Taiwan is what? What is our best part of our AI in Taiwan? And what is the major difference between AI, DR in Taiwan and China?
Okay, thank Professor Du for your questions. And I have to say that the Changhua Christian Hospital is always the best model, or the best one that other hospitals should learn. Just as Professor Du said, they already had the top 1 screening rate for the DR among the hospital in Taiwan, but they still adopt the AI system to make it better and more efficient. That's what we have to learn. And just as you said, maybe after using it in the real world practicing, we can upgrade in the future for the VeriSee DR. For example, now what we are doing is to diagnose the so-called referable DR. After their patients are diagnosed as the referable, they have to visit the ophthalmologist. Why? Because according to the color fundus photography, we can diagnose they are severe NPDR. But why they still have to visit the ophthalmologist? Because we don't have to receive treatment for the severe NPDR. Because maybe there are some cases they are actually PDR, but they can only be diagnosed after they receive the examination of the fluorescein angiography. Only by the color fundus photography, we cannot really diagnose the small MV. But maybe in the future, after we collect the data, we can try to make the diagnosis of the small MV from the color fundus only. That means that we can do VeriSee DR might be able to the more accurate diagnosis than the ophthalmologist, because in the past we used the gold standard by the ophthalmologist using the color fundus photography. If we can use the fluorescein angiography as the gold standard, it might be there might be a chance that VeriSee DR can perform better than ophthalmologist.
So I think our time is out.
The second question is, all around the world, they have a lot of AI for DM retinopathy. What is the best part of Acer AI for DR or other product from other company?
I can answer some, maybe Amy can answer more later. For the VeriSee DR first, during the model development, we used the IPEX open access data, which included the Westerner, included Caucasians or from some other races Latino, etc. And also the data from Taiwan, which is mainly Asians. And during the validation stage, now we still incorporate the data from other countries, from Southeast Asians, from Japan, and even from the Europe. So that's why we can say that it is useful for many different races. I think this is one of the advantage over other similar softwares.
Yes, like Dr. Hsieh said, we really fine-tuned it using the Asian population data. So it's definitely more suitable for the Asian population right now. And other than that, I think it's really how Acer Healthcare really understands the importance of integrating the system seamlessly into the current clinical workflow. We already have experience working with CTH as well as other medical centers and clinics in Taiwan. So we understand the medical community's needs. And I think the seamless integration and customization part really helps the medical community in adopting AI solutions into their current clinical workflow much easier and better.
Okay, so thank you so much for our three speakers. Then our time is out, so I have to close today's seminar. Thank you again. Thank you so much. Thank you for your joining. Yeah, bye.
Thank you all. Thank you.
Bye.
Nina.
Thank you.